Thanks, Rahul. Thanks, Jim. It's tough to follow that. That was amazing. But I'll try to give you an update of where we are with endovascular therapy. So what's been going on in the last few years? I think we've seen an accelerated sort of growth phase for pulmonary embolism, and particularly with device. Could you please set that to 8 minutes? I believe I have 8 minutes for this talk, and I'm going to need every single second. Thank you. So in 2014, we had the Pytho Trial published in New England Journal of Medicine. We had 3 large meta-analyses on systemic thrombolytics, and the first randomized trial for CDT, the Ultima trial, that was published in Circulation. 2015, Seattle 2 was published in JACC. A large prospective CDT registry was published in CHEST, called the Perfect Registry. In 2017, the long-term outcomes from the systemic thrombolysis pivotal study Pytho were published. The ELOPE prospective observational study, which redefined how we think about the post-PE syndrome, was published. And the Optelyse PE results were announced in that year as well. So you can see that this has been an exciting time ever since 2014 hit. But we're not done. We have other things coming down the pipe. So we have an angiovac registry that will define what the use of this device is in VTE. The FLARE trial by Inari FlowTriever, you can see this funky device that it can remove thrombus from the pulmonary arteries as well. The Extract PE trial is currently ongoing, and it uses an 8 French device to try to remove thrombus. National trials are on the verge as well. The PERT Consortium registry is hopefully up and running soon. We are trying to get this trial called ptrap off the ground as well to figure out if we should be routinely using catheter-directed therapy for submassive PE. You've seen this slide before from Keith. I'm not going to belabor it. Suffice it to say that we have different roles for each one of these stratifications. So we've seen this as well. I think the point I wish to make is if you drew a line across here, this is where you could divide submassive and massive PE, and they are different diseases, but they are on a spectrum. So if we're talking about massive PE, and you go back to this slide, with this 25 to 65% mortality, what are we trying to do? We're basically trying to rescue these patients from death. This multidisciplinary team of physicians that's treating massive PE is trying to do this. The tools that we have to do this are intravenous thrombolysis, CDT, and surgical embolectomy. Most commonly, patients with massive PE should be receiving intravenous thrombolysis. However, there are patients in whom they're contraindicated, thrombolytics will fail, or an alternative is preferred. In those patients, you have surgical embolectomy and catheter-based therapies. The focus of this talk is catheter therapies. We talked about some of the devices that can be used. This is the cleaner device. I'll elucidate it in a little bit as well. My point with massive PE and endovascular therapy is that you can throw the kitchen sink at this disease because it's such a difficult disease in terms of mortality. I want to show you one case of a massive PE. This is a case that launched the PERT in my previous institution. 30-year-old man, transcranial resection of a pituitary tumor, post-op seizures, had an intracranial frontal lobe hemorrhage. Then, after that, developed hypotension and hypoxia and was diagnosed with a pulmonary embolism that looked like this. Basically, a totally occlusive clot in his right pulmonary artery, clot in transit. He was not a candidate for systemic lytics. Our surgeon was not available for this case, and so he came to the IR suite. He had systolics of 90 millimeters of mercury for an hour. He was getting more altered and tachycardic. He was started on pressors, and this was our directed injection from neck approach, showing this cast of thrombus and no perfusion to the right lung. Tried a little bit of TPA, tried some aspiration, some maceration with a pigtail. None of it was really working that well. Thought about this device before for PE, thought I'd try it out because I didn't have a lot to lose at this point. Activated it, patient actually started coughing, I freaked out, but ultimately we actually got a little bit of improvement in this, and you can see there's more perfusion. It's not a perfect picture, but you can see that the aorta is now filling with the directed injection. There's not a ton of data. The best analysis done so far was by Wilco in 2009. This success rate implies that every single patient with massive PE should be undergoing endovascular therapy. I would argue, however, that the studies that made this up, only 94 were prospective, 500 were retrospective single-center studies. And we cannot forget about surgical embolectomy and ECMO. These are life-saving maneuvers, and this sort of thrombus is something we just don't have the capability of doing with catheters at this point. Submassive PE, far more controversial. You can see the mortality is much lower. It does have a higher rate of decompensation than low-risk PE. So what do we do with these patients, and why are we trying to do it? Are we trying to prevent mortality, hemodynamic deterioration, prevent long-term disability? Quite frankly, we don't know yet. Where did this concept come from, though? In 1999, the ICOPER study showed that patients with right ventricular hypokinesis had a higher 3-month mortality than those without. This all led up to the Pytho trial, which was supposed to answer all uncertainty. Dr. Sterling referenced this trial. Basically, what it showed is that the placebo group, or the non-lytic group, met the primary outcome more commonly, and this is not an outcome you wanted to have, of death and hemodynamic decompensation more often than the tenecteplase group. So we should use systemic lytics to try to prevent hemodynamic decompensation, right? Well, the problem was the bleeding. As Dr. Sterling alluded to, major bleeding was higher. A 2% intracranial hemorrhage rate made it unacceptable for routine use. So many of us have concluded that systemic thrombolysis has a questionable risk-benefit profile for submassive PE. What about catheter-directed therapy? Is there an opening here? Is it safer, and can it do the same thing, is the question. You know, the concept here is, instead of having a systemically administered drug bounce off the clot, you place a catheter, you embed it in the clot, and you start leaking in a fibrinolytic drug over time. It's safer, as effective, and you get the same efficacy results as you do with systemic lysis. This is the poster child of CDT. You have a patient who has a high systolic pressure, this excavating thrombus, same in the left lower lobe. You put in bilateral infusion catheters, 24 hours later, 1 milligram an hour. It looks pristine, the pressure is down, and the patient is feeling very good. But what do we have as far as CDT trials beyond these anecdotes? Well, we have the Ultima trial with 59 patients. We have Seattle 2 with 150, and we have the Perfect Registry with 100. Now, the Ultima trial is the only one of these that is randomized. So out of the 1,700 patients that have been randomized in systemic lytic trials comparatively, we have only 60 in CDT. Ultima is really the only one that's shown a comparative difference between heparin and CDT, which showed a reduction in the RV to LV ratio at 24 hours, but no clinical outcomes associated with this that could be statistically evaluated. PA pressure reduction. We also look at the safety, and from Seattle 2, there was an 11% major bleeding rate. It was a conservative measure of bleeding, but it was there. Importantly, there were no intracranial hemorrhages. This meta-analysis, what we sort of have come upon is that major bleeding happens in about 4% of cases, and intracranial hemorrhage is much rarer, on the order of 0.3 to 0.5%. Can we remove clot without thrombolysis? It's possible, but we have a lot of work to do. This is the Penumbra Cat8 device. This was a series of 6 patients. We're trying to understand these aspiration catheters better. So basically, we need a lot more data on safety and short and long-term clinical outcomes for CDT to be routinely used for submassive PE. Also, we need to rectify this discrepancy of 1,500 patients for systemic lytic trials versus 59 in a non-US trial. Should CDT be used routinely? Well, we're in a state of limbo right now. When you're on your PERT, you could be like Aristotle and Plato and debate the merits of CDT or no CDT. But we don't have the data, and this is sort of indicating the CDT roller coaster that we're on, in which you have all of these patients who, or you have all of these activations going along with CDT. Maybe you have a complication, it drops, and you go up and down like that. We need better data to overcome this. Interventionalists believe in this, non-interventionalists not so much. So we're trying to conduct the ptrap trial. I hope this will be funded in the next year or two. But basically, this is an RCT of CDT versus no CDT for submassive PE, looking at clinically relevant outcomes. It does not exclude cancer patients. A lot of patients we plan to enroll in this trial across the country. In conclusion, when do I actually escalate therapy for submassive PE? Really, these patients who are bordering on massive, they have a lactate, they have signs of hypoperfusion, some sort of reperfusion is indicated. The high-risk submassive, it's still, quite frankly, the jury is still out. We don't totally know, but possibly. In low risk, probably you shouldn't be routinely doing that. PE research and interest are in the exponential growth part. All comes down to the RV. Massive PE, rescue with anything possible, and I think for submassive PE, we still don't have adequate data to know what to do routinely other than anticoagulation. Thank you.